Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. Today, I'm joined by my fun, fabulous, feisty friends, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hello.
and Dr. Susan Hudson from Texas Fertility Center.
Hello. How are y'all doing today?
Doing great. Well, boy, I'm excited. We finally made that change over past Memorial Day. We're heading into summer. And so, you guys live in hotter environments than I do. And so we were kind of talking a little bit about which bothers you more, extreme cold or extreme heat. So Carrie, you're up first. You live in a really hot environment in the summertime because I was there last summer when it was blazing hot, like
Yeah, which
107
I
hot.
mean, the rates are good at the hotels in the middle of July, but there's a reason for that.
Yeah, I learned that. I learned that.
So I would much rather have extreme heat than extreme cold because I did residency in Cleveland
Ah,
and
you've been in
even
both
fellowship that I did in
environments.
Atlanta. I mean, it was colder than here. And I grew up in Arizona, and this cold business is for the birds. I mean, I could never get warm. I understand there's an argument that you can only take off so many clothes, but there is a counter argument that you can only put on so many clothes, and we don't have enough money to support the heating bill that it would take for me to live in one of those places now. And so Vegas and further south is where we shall stay.
So
I
Susan, you
I
have
have
also been in extreme heat and extreme cold. So
I have been
what's
in
your
extreme heat and
take?
extreme cold, and I can say that prior to my 3-year foray in Minnesota for fellowship, prior to then, I thought I would prefer cold because like I don't like if it gets over, I mean, I'm not real picky. I'm like, if it gets over 100, I don't feel good. I don't like that. I mean, I get sunburned. I'm a pale redhead. Like it doesn't work with me. I mean, and I feel like crap when it's like super, super hot. You tend to get dehydrated and all that crap. But, now that I had the 3 years in Minnesota, I agree with Carrie because I was always like, oh, you can always add on more clothes. You can only take off so much, and even then, it's not going to do you any good. But heat doesn't cause pain. And oh my goodness, the pain that you can have from being too cold. I mean,
Yeah.
this sounds really terrible, but this is kind of funny in the same respect. So we lived probably about 10 minutes from the hospital. I mean, Rochester, Minnesota is only at well, at the time was only about 100,000 people. So it's not a huge city. And so we lived kind of on the outskirts of town, but it was only 10 minutes to the hospital. And going to work wasn't too bad when it was super cold because your car was or truck, we had a truck at the time that I drove,
Mhm.
was in the garage. And even though your garage was cold, you could get it warmed up and it wasn't that bad going in. But when you had your car outside and even in the parking garage because the wind's hitting it all day, the inside of it would get so cold that when you were coming home, it was that cold until pretty much you got home because it took that long to warm it up. Um, and my hands would hurt so bad by the time
Yes.
I got home that I was pretty darn grumpy. And I was so grumpy, my husband started driving me to and from work so that he wouldn't have to put up with me after I got home from work because I was in pain. Oh my
Yeah.
goodness. But I have, still have the same wonderful husband. We're about to have our 25th wedding anniversary. So yay.
Yeah.
Um, but it was just, it was absolutely amazing that cold could be that painful and until you experience it like day after day after day. So yeah,
Yeah.
I vote for heat over cold. Though I do enjoy visiting cold. Like I love visiting cold. I just don't want to be there permanently.
Yeah, I would agree. I haven't been in the extremes that you guys have, but my husband is from Iowa, Northwest Iowa, and we've been there a couple of winters. And when it's just, blazing, like we were there for the polar vortex when with the wind chill was minus 24. That is the coldest environment I've ever been in. And then last summer, when I was out in Las Vegas, it was 107. And oh my gosh, the wind would blow and it would feel like somebody's blowing like a hair dryer down your throat. It was like awful. So the extremes are really bad. But if I had to choose one or the other, I would pick the heat over the cold any day of the week. Same thing. I don't like being cold, but I have experienced both briefly, fortunately.
Yeah.
So, well, today we're going to talk about a topic that we have a lot of questions on. We're going to try and hit as many as we can. We're going to talk about recurrent pregnancy loss. And so hopefully we'll be able to answer some of the questions that you may have if you have that condition. So what do you got for us, Susan?
Some of these questions are just on pregnancy loss, not necessarily recurrent loss, but recurrent loss does tend to be a theme. So that's what we're all trying to obviously prevent. Okay, so our first question is multiple recurring chemical pregnancies. Thank you so much for your insights. I'm a 29-year-old woman, AMH of 30, been trying for over a year, got pregnant almost every cycle naturally, but the pregnancy test begins fading and I get my period. This has happened 8 times. 4D scan is fine. Biopsy of the uterus was fine, no painful, and all blood work has been normal. Previously had a copper IUD for 5 years and OCPs for 4 years. Only thing to note that she has had her appendix removed. Tried progesterone from 5 days post-ovulation for a few cycles. Oral estrogen is lining with 7, and Clexane, CLEXANE injections. She has a hycosi booked. Is there anything else I can try for chemical pregnancies?
Has she done any other testing? I mean, she's done testing, but she's not gone the way of IVF yet, right? To check genetics.
Correct. She's only conceived naturally.
So based on what she's saying, she's had a uterine evaluation, she's had blood testing, although we don't know what blood testing she's had done. She's gonna have, has she had a karyotype done, did she say?
She said blood work. So why don't we cover just because this is the beginning of an episode regarding pregnancy loss. If we have somebody with recurrent pregnancy loss, what are the main parts of the evaluation we want to make sure we cover?
So uterine evaluation was either an office procedure or surgical procedure to look inside the cavity. We want to do serum testing. We want to do things like a chromosome testing on you and your partner to make sure that there's not some structural abnormality of the chromosome. We want to do some immunologic testing, things like lupus anticoagulant and anticardiolipin antibodies, which are basically just blood tests where we look at some genetic, or I'm sorry, some autoimmune things that could be a problem. Sometimes we'll check some clotting disorders, although there's not really data that supports that, but many of us do that. And essentially, we'll do those things first, and then sometimes we'll treat empirically with some things like progesterone and aspirin, things like that.
When you're looking at uterine evaluation, doing a saline ultrasound in addition to a regular vaginal ultrasound is very helpful. A lot of times we'll want to do a hysteroscopy as well, just because of the direct visualization benefit that we can get with that, to see if there's any inflammation there. You know, she's had some, I mean, she's already taken the Clexane, which is also known as enoxaparin or Lovenox. It's a blood thinner. And so she's kind of treated some of the things that we look for already. I would be very interested in seeing what her hycosi results are because she's scheduled for that. Mostly because we want to see if there's any tubal abnormality, because one of the biggest, scariest things we worry about with the situation that she's described of multiple biochemicals, where your urine test turns positive and then it goes negative very shortly thereafter, is we worry that a pregnancy has occurred, but it's gotten caught in the tubes. And fortunately, if the tubes if the pregnancy is recognized and it stops growing, that is not a scary, threatening scenario. But if one does continue to grow, then we worry that could actually result in far bigger health concerns. And so getting those tubes tested is important to make sure that these biochemicals are not occurring in the tubes rather than the uterus.
Would you say that an HSG might give you better visualization if we're worried about things like hydrosalpinx than a hycosi would give us?
I mean, in our practice, we typically, if it's a tube issue, we lean more toward doing HSG just because it's a little bit more cut and dried. But I think either or is fine.
Yeah, I mean, you're pushing fluid through, and so you can see the fluid collection because you're watching with the ultrasound the entire time.
But if
So
it's a patent hydrosalpinx, so an open hydrosalpinx, well, I don't do that much hycosi. I mainly do HSGs. How good a visualization of a hydro are you going to get if the tube is open?
I
It
think the
depends.
HSG is probably better just because you've got more
Yeah.
stills and it's probably less user dependent.
Yes, I
I
agree. Yes.
I think with a good operator, I think it's probably pretty similar, but if there's any question, get the HSG because you're going to have pictures and you can go in and look yourself.
Yeah.
All right. Very good. Very good. Okay, so our next question is, hi, would love your thoughts on our case. I'm 35 and a half, started trying for my second 10 months ago, have had 3 losses at 8 weeks due to trisomy 16 and 2 chemicals. My OB tested my AMH level and and it was 1.2, saw an RA 3 months later, and AMH was 0.74, FSH of 7.55, estradiol 41. Blood work and HSG are normal. Husband's sperm is normal. RA thinks I have a worse egg quality than typical 35-year-old due to my loss history. Extra background, we conceived my son now 2 after 6 months when I was 33, but we had 2 chemical pregnancies during that attempt. Based on my loss history, do y'all think it's likely my egg quality is worse than the typical 35, 36-year-old?
It's
AMH you
entirely
said was,
possible. That number of biochemicals is definitely enough to merit, the full workup evaluation, looking at karyotype, where we're checking the number of chromosomes and are they arranged appropriately is helpful. This is the kind of situation where you always just wonder, okay, if we did IVF and we did PGTA to look at the composition of the chromosomes, like, is this maybe a patient who would benefit by that more than some of our other patients with recurrent losses? I mean, I don't think anybody's got the answer to that, but that's kind of where my mind goes of, if this really is a genetic issue, let's see if we can just
Put back
catch
the
that before.
chromosomally normal embryo. Yeah.
Yeah. Yeah.
I,
And then see.
After having a normal karyotype on both parents, what I usually counsel my patients when they're considering IVF is most of my recurrent pregnancy loss patients, I don't necessarily get more chromosomally abnormal embryos. I think they just happen to stick longer in certain women than others, and that leads to a lot of these biochemicals. But making sure you've had the full evaluation, and again, a lot of this comes down to where your heart and your mind come together for a decision.
well, one thing about IVF too that we always talk about is that, when you have a pregnancy loss, we know about 50% of the time it's due to a genetic abnormality. And that may not be the whole problem, but we can certainly lessen the number of biochemicals that you will have most likely if we do IVF and we do genetic testing and we know that we're transferring a genetically normal embryo. So for patients like this, after a while, I think you just emotionally and physically, you sort of become drained and you're like, if you're to the point where you're like, I can't keep doing this, then
Right.
IVF would probably be the next best step.
But back to your question, if you've had that significant drop in your AMH, this could be an egg, I usually think of AMH being more tied to egg quantity than quality.
Yeah.
Um, but we do see people who have recurrent pregnancy loss, and really their primary reason for it is egg quality. So it definitely could be a contributing factor, because there's definitely overlap in that quality versus quantity
Mhm.
representation in the AMH. All right, our next one. Um, let's see. Hello, ladies. Could you talk about a blighted ovum at 6 weeks? My daughter just had one with a chemical the month before that. She is trying to have her second child. She has a 19-month-old who she is breastfeeding. She did not require medication or DNC. When can she try again? Should she have more tests? Thank you.
Usually blighted ovums are linked with a genetic abnormality where there's an extra chromosome. Usually it's trisomy 16. And so, but that's just sort of the genetic lottery. It doesn't necessarily mean that that will be recurrent. The fact that she has a healthy baby at home tells us that, eggs were good. And, this was probably just a fluke. I mean, just sounds like she's probably a pretty fertile person. And in terms of when she can try again, I think most of us would agree that once her hormone levels have gone down to normal again, and she's had some sort of uterine evaluation. Some people would do that, some people wouldn't, but we do generally in our practice. Then really the cycle after that, she can really get going again pretty quickly.
I would say that, I know she had a biochemical and then she had the blighted ovum. And to me, that's recurrent pregnancy loss. So I would recommend a recurrent pregnancy loss evaluation. Now, there's some people who are like, oh, it needs to be, we need to see a baby in the uterus and that type of thing before that type of evaluation. And I've seen my share of people who have been kind of brushed off in that way and come to find out there was actually something else going on. So I would recommend an evaluation. As to trying again, there's reasonable evidence to say actually your best chances of being successful are in the first few months after a miscarriage. So as long as she is emotionally ready to start to try again from a medical perspective, she's probably good to go.
Most of the time, miscarriages don't result in a whole lot of physical drama. I mean, every so often you'll have someone who encounters issues with bleeding or the entire pregnancy not emptying out of the uterus completely. But more often than not, that's not an issue. And so it really does come down to an endurance test and resilience and how many times you can get knocked over and stand back up again. And that's not fair, but in some ways it's also a very equalizing approach because it just means you just have to get up one more time than you've been knocked down. We just don't know if you're going to be knocked down twice or 20 times, and that's what makes it hard.
Yeah. It's a challenge. It's a challenge. All right, our next one. Thank you for the wonderful service you provide in giving context to fertility treatments. Thank you for listening. My question has to do with being diagnosed with a blighted ovum after a normal PGT tested embryo, grade 4BB embryo. I've managed to get pregnant naturally 2 times in the last 13 months and 1 time via IVF. At my week 6, 5-day scan, there was no visible fetal pull and heartbeat. I had hoped doing IVF and ICSI would prevent me from experiencing this again. I have 1 living child born in early 2021 naturally. All of my miscarriages have been missed miscarriages, 2 with normally rising betas. I feel like I can't trust the science anymore. No real issues beyond MTHFR mutation in RPL. Any other tests we should do?
So one thing that pops into my mind with this, which is oftentimes an issue with patients who had losses, is that the main 2 criteria that we have to judge embryos before they go back in, one is going to be PGTA, whether or not you have the correct number of chromosomes, which is one of the better tests that we have, but is certainly not foolproof because it's not necessarily looking at each and every gene that's got to be fully functioning in order for this to happen. And the other thing that we look at is the morphology or the appearance of the embryo and whether or not it looks like the parts and pieces that need to be there are there. There's some differences when you look at the embryo morphologically under a high-powered microscope versus a lower-powered microscope. Something that looks great under low power, when you really zoom in, is not necessarily great under high power. And so something that could very easily merit a legit 4BB grade is not actually 4BB when you zoom in. The other thing is, even if everything is exactly as advertised with normal PGTA and good morphology, there's a lot of other work that's got to go on. I mean, the blastocyst is, and those cells are filled with all these little organelles, so many little organs that do the work of getting that blast to grow and turn into a baby. And even if the instructions are completely accurate and you know that you've got good PGTA and those instructions are good, it doesn't mean the machinery is functioning all that well. And that's one of the big things we see, especially with older moms, is that there's nobody putting WD-40 on those gears. And so things go boing.
One thing I wanted to comment on is that you mentioned MTHFR mutation, and for our listeners, I just wanted to let y'all know that, and this is something we deal with all the time in our practices. Somebody gets tested for MTHFR, and really, I want you to know that the data says that first of all, MTHFR mutations are present, I believe, in about 15% of the population. Okay, and that really the miscarriages that we're really concerned about MTHFR are 2nd and 3rd trimester miscarriages, not these blighted ovums, not the biochemicals, not the 1st trimester miscarriages, which are going to be 95% of the miscarriages that we see. So, I'm sure y'all always get people are like, test my MTHFR. I need to know. And it's like, we can, but realize that the information really isn't supportive of doing that test in response to what this clinical indication is.
Yeah, and just to piggyback onto what Carrie said and to what our listener said about she feels like science has failed her. The tricky thing and the thing that's so frustrating for all of us is there's so many things we don't know about reproduction. The things that we don't know about reproduction are this big, and the things we know about reproduction are just tiny. And so one time I was at our national meeting, and this woman had spent her whole entire like 20 something year career doing research in what happens in the first 24 hours when an egg and a sperm go together. So we put a lot of importance on the genetic testing, which is really important because if you don't have that, then we know it's not going to work out well. But there's probably so many other things. And hopefully over the next several years, science will start to teach us other things to look at other than genetic testing. Because just like you, we all have had the experience, in fact, have a lot of times where we put a really beautiful, nice, normal embryo in a patient. The transfer is very easy. Everything goes perfectly. All the metrics that we look at, like the endometrial lining looks great, and just everything about the transfer goes great, and you don't get pregnant. And it's really frustrating and upsetting to all of us. And I wish science had given us more information about implantation. There's just lots of things we don't understand right now, unfortunately.
And along with that is remember that when you are experiencing losses, it is normal to go through the grieving process and all the stages of the grieving process. And you and your partner are going to go through the grieving process, and you're not necessarily going to be at the same stage as each other. And that is also normal. And so I often recommend people who are really kind of struggling with figuring out what to do next, where are we, as a couple, really potentially looking into some counseling, grief counseling, fertility specific counseling, because this is a challenge. This is a really serious emotional thing that you're going through, and one of the hardest things you're going to go through. And we want to make sure that you have all the resources you need to navigate this successfully.
Definitely agreed.
All right, our next question. Are miscarriage rates lower with IVF? I'm 5 weeks pregnant after a day 5 frozen embryo transfer of a 5AA embryo that had normal PGTA testing. Just nervous because I had a miscarriage at 8 weeks with a prior natural pregnancy.
Yes, 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 they're lower. Because like we were just talking about earlier, we take out part of the part that's scary, the genetic component. And if we know that we put a normal embryo in you, we're correct 98 to 99% of the time. And that gives you a huge jump on having a healthy pregnancy. So the good news is, and maybe by the time you hear this, you'll already have a good pregnancy and you'll know about that. But great majority of people who have a genetically normal embryo transferred have lower miscarriage rates and much higher ongoing pregnancy rates.
Good stuff. All right, next one. Hey, y'all, I love listening and learning from your podcast. I appreciate all the work y'all do. I'm 26 and my husband's 28. We've been trying for 2.5 years, AMH of 3.31, normal thyroid, A1C 4.6, HSG stellar, and ovulate regularly on cycle day 13. Husband's semen analysis was normal. In about 6 months ago, started using UPTs at cycle day 10 when I missed my period. In September 23, I had a positive urine and blood test, but ended up being chemical, normal cycles again in a couple months later, and had a positive urine blood test about 3 months later, chemical as well. My OB is starting me on letrozole, 2.5 milligrams next cycle. What would y'all recommend treatment-wise? Thanks. I think this listener needs to go see a reproductive endocrinologist and have a fertility evaluation. I mean, it doesn't sound like your problem is getting pregnant. And so using letrozole usually is used to help you get pregnant a little quicker, not necessarily to fix a problem that's causing recurrent pregnancy loss. So I would recommend probably visiting with a reproductive endocrinologist to have a full evaluation looking at potential causes of pregnancy loss that we've mentioned.
Yeah, I would agree with all that. Having someone who's used to seeing it time and time again and who's going to see you getting pregnant with the same urgency that you do can be really helpful.
All right, next one. Hi, I'm 38, no living children, 3 first trimester miscarriages. First was genetically normal. Second was a biochemical. Third, DNC showed partial molar pregnancy. No red flags found on husband's fertility workups except for MTHFR mutation. Did 3 rounds of IVF in 2022 when she was 36. 8 embryos, 3 PGT normal. Transferred highest graded in December and ended up with a corneal ectopic pregnancy, 2 doses of methotrexate, but heartbeat and growth remained. They did a corneal wedge resection and lost the left tube. We have to wait 6 months to try another FET, trying to decide if I should consider another egg retrieval. How good are my chances with remaining 2 embryos? Thank you very much.
I think
So
this
she's
depends
been
a
through
little
lot.
bit on what your goals are.
What,
You know,
before we get to that, can we talk a little bit about what a corneal pregnancy is for our listeners?
So corneal pregnancies are functionally, they're ectopic pregnancies in terms of they're located in a place where they really can't grow. The difference with a corneal is that it's up in the teeniest, tiniest part of the uterus, right before the tubes are fully branched out into the tube. So it's in the tube, but it's in the tube that's still in the uterus. And
yeah,
so
in the muscle of the uterus.
it's in the muscle of the uterus. And so
Yeah.
what is so dangerous about those is that when you have an ectopic pregnancy that's growing further out in the tube, it gets big, it blows out, once it gets too big, and if it's not caught, people start bleeding and they have pain and they go in right away. And they have to surgically take it out. With a corneal, you are in a much scarier place because taking a tube out where you can see both sides of the tube right around where you need to cut out is a lot easier than having to do a major surgery when you've got major bleeding, to take out a chunk of the uterus, because the uterus is a much bigger, thicker, hardier organ, which is
It has
great
a
when you're
lot
talking
more
about,
blood supply than the
it's great
tube.
when you're talking about a baby, but there's a ton of blood going there. And so it's a harder, more complex surgery. And so
Much harder.
that's why we worry about corneals, is because they're in a scary place.
Okay, so chances of getting pregnant with her PGT tested embryos created at 36.
Really good. She has 2 of them, I think,
Yes.
remaining. And, and I would say close to 70% chance, in at least in our practices, I would say, of getting pregnant with each one of those. So it really depends on kind of, at 38, if you wanted to go through again to make more embryos, if you thought maybe you wanted more than 2 babies. And, it's hard to know for sure if both of those would implant, but pretty good chance at least one of them would. So if your goal is to have 1 baby, then maybe not. But if your goal is to have, 2 or certainly more than that, then I would say, yeah, it'd probably be a good idea to go through IVF again to see if you could get a normal embryo to implant or to have to use in the future.
I agree with that. All right, let's do a couple more. Okay. Hello, I'm dealing with secondary infertility. I had my daughter naturally with no problem, but then had 3 miscarriages. I recently started seeing a fertility doctor and they did the whole workup, saline sono, all the blood work, along with seeing a hematologist. From all the testing we discovered, I had a C-section defect, an isthmocele. There's no way to tell if the miscarriages are related, but everything else came back normal, even for my husband. I repaired the defect, and with a repeat saline sono, it looks like it healed great. I was told to wait 6 months to try it again to fully heal. The plan is to do Clomid intercourse. How common is the C-section defect, and why would this happen? I did have choreo infection during delivery.
I don't know if anybody knows the data on how common it is, but we certainly, I mean, it's not unusual at all when somebody's had even 1 C-section. When you look with ultrasound, you can see a divot there. It's just a thinner area. And in my experience, the more C-sections that patients have had, the more you tend to see a thinner myometrium or muscle over. Just because you have a C-section defect doesn't necessarily mean that it can cause a problem, although in some patients, it can collect fluid there and collect blood. And we don't really understand the mechanism, but we think that maybe that blood's refluxing back into the uterus and making it more difficult for a pregnancy to occur. Some people, I was interested to hear that you had that repaired, because a lot of people now are less inclined to get it repaired because there's really not data to show that it makes a difference. But, on the flip side, there's probably not a lot of people that have had repairs. So it's really, there's not a good group to look at. but I'm glad that it's repaired, has gone well for you. In terms of how, the likelihood of choreo causing that, I don't think anybody knows the answer to that. I think there's a lot of people that have choreo and still heal, well from their C-section scar.
Mm-hmm.
Yeah.
And I mean, also remember that even with a completely normal evaluation, half of the embryos you create are chromosomally abnormal. So yes, you have had the C-section defect, but statistically, probably it's more likely that these may have been due to or at least some of them have been due to being chromosomally abnormal.
Mm-hmm.
All right, one more. Okay, hello, my fantabulous dogs. Oh, I love them already.
Yay.
Feeling pretty blue. I'm 38 now. Had a blighted ovum in October of 22, banked embryos spring of 23, 2 PGT normals, conceived again spontaneously in December 23, currently pregnant. HCG is sluggish, 1900 at 6 weeks, so rising up to this point. And although fetal pull is visible, doc is concerned about viability. No sign of period. Strongly suspect I conceived back a few months earlier as well. Had 5 days of cramping, which was unusual, though negative pregnancy test. I'd love to achieve 1 spontaneous pregnancy for child 1 and use my banked normals for child 2 when I'm able. Do I transfer, try at home, bank more embryos? AMH is 1.4 to 1.8, FSH is 7.8, estradiol 64, TSH normal. Has hubby sperm very low on morphology, otherwise normal.
This is where a sperm QT might actually be helpful on hubby, just to see if there's anything easily identifiable there.
And
So why
Carrie,
don't we
what's
talk about what sperm QT does?
So we had a sperm QT episode that was, give me a minute and I'll figure out the number, but it was somewhere around the 180s, I think, in terms of our episode numbers. But it looks at the function of the sperm, 184. Episode 184. And so it looks at the function of the sperm. So not the analysis, which is looking at whether it's there, what kind of numbers, and is it moving, but once the sperm QT looks at once it's where it needs to be, can it actually break in and get into the egg and start the next set of steps. And so sometimes we'll see patients who have a poor sperm QT result that they can get pregnant, but they don't do as well in pregnancy and they have losses a little bit more frequently. They don't have the finalized data on that. That was just something that, I noticed when I was looking at the data with them. So I'm super curious to see what comes of that.
The more recent data, they were in our office probably about 3 weeks ago, and they're collecting more and more data where they're seeing that if you have an abnormal sperm QT, you almost never gets pregnant. I mean, it's like pretty significant data. I think they're going to present at our next ASRN meeting.
I think that's Susan's data.
It is.
Oh, is it?
Yeah, they have some larger group data, but they've also taken data specifically from my clinic. And
that's right. I forgot because they kept saying Dr. Susan Hudson, Dr. Susan Hudson. I'm like, yeah, I kind of know her. That's why they kept. I didn't realize it was mostly your data. Sorry, I misspoke. You should. It
was TFC data, but I probably use sperm QT more than anybody else in the practice.
I started using it more because of Dr. Susan Hudson's data, actually.
It's really compelling data. It's kind of
cool. Is really compelling data. I mean, Dr. Susan.
It's like you know what you're doing, but you don't necessarily. So for our listeners, when we're looking at success rates, like our IVF success rates are monitored to the letter, whereas success rates for IUIs, like we have studies and that type of thing, but IUI success rates are very hard to kind of pin down because I mean, in all of our practices, there are definitely people who do IUIs who should be doing IVF but are choosing not to do so. So they're kind of a mixed bag. And so what we've seen in my patient population is that with an abnormal sperm QT, and I do probably a sperm QT on probably about 40 to 50% of my male population, that with an abnormal sperm QT, if they choose to try to get pregnant with IUI, they are probably not going to be successful. Yeah. Whereas if they move on to IVF, they actually have very, very good chances of success.
How many people were in your population that you looked at?
I honestly don't know how many people they pulled this information through our lab and everything like that. And so it was, I don't know the details of all of it. It was just one of
To be
those, like,
continued then, huh?
it
You'll let us
is
know.
to be continued. But I do think that, keep up, keep trying. And a lot of whether you want to do more embryos has to do with the family size that you choose to have. If you're, if you have some banked embryos and you only want one baby, or you feel like your life will be complete with one baby, then go forward with embryo transfers. If you feel like, we really, really want to have a family of more than one child, then this is the time to bank embryos. It is not 2 years down the line, because no matter how hard it is for you to get and stay pregnant right now, it is not going to be easier in the future. It doesn't mean we can't make it happen in the future, but it's not going to be easier. So your best chances are embryos created now. And that goes for everybody.
That's right.
Yes.
All right. I think that's good for today.
Awesome.
Very good. Well, to our audience, thanks for listening, and tune in next week for more. Be sure and subscribe and leave us a review in iTunes. We'd love to hear from you. You can follow us on Instagram and Facebook. So hop on and leave us a like or a comment.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. Questions will be answered on the podcast anonymously, so don't hold back. We love episode ideas, so let us know what you're thinking and want to hear. And we'd love to hear book ideas too, because we are actively in the middle of writing that. And so would love your input to know what you want to know and what would be helpful for you as we're going through that process.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. We'll talk to you soon. Bye.
Bye.